Thanks, Danny, and thanks to Julia and everybody else at HERDA. It's great that you're addressing. I think this is a really important issue that many systems of our members around the country are working on. Danny, I think if you can run my PowerPoint, because I don't seem to be able to do a, wait a minute. Yeah, I can, my fault. I'll share my screen here. I hope everyone can see that. What we're going to talk about today are kind of as the title implies, the connections between social determinants of health, SDOH, which is a phrase that we'll go into a little more detail on, and community-based public transportation. I'm Scott Bogren. I'm the Executive Director of the Community Transportation Association of America. We're a nonprofit membership association in Washington, D.C. We represent about 1,200 public transportation systems and operators around the country, and have been operating and working within kind of the non-emergency medical transportation space for quite a bit. For a long time, we try to provide our members with resources. We do advocacy work around this issue. We work very closely with the Federal Transit Administration and kind of have a long organizational history with the connections between good mobility and good healthcare outcomes, which I think is, when you really boil it down, that's what we're talking about today. That's kind of a quick breakdown of our membership. You can see rural operators are our largest membership group, followed by smaller cities. We also have a number of members that do specialized transportation, typically for older adults and people with disabilities, but that can also be for veterans. And a lot of NEMT operators, federal, state agencies and such are all kind of a big, all are important parts of our membership groups. As I mentioned, we train about 50,000 drivers a year in passenger safety and sensitivity. A lot of drivers in the non-emergency medical transportation space, or NEMT. We do a lot of training for advocacy, resources, and technical assistance. We provide all of those services to our members and to the industry. So I wanted to kind of talk a little bit, just so we're all in agreement and know kind of, we breeze past oftentimes like, well, what are the social determinants of health? And this is a slide that gets very much into the very specifics of that. Basically, they're the different determinants that impact one's health. Housing, transportation, education, work, access to healthy foods, the cleanliness of the local environment, all those things are part of the social determinants of health. And in the last 5 years, we've really seen this increase in the connectivity between effective mobility and the social determinants of health. And this is a broader effort to really look at and understand all the different aspects that impact one's health, and to take it beyond merely access to doctors and hospitals and more into the varying influences on one's health. That's what kind of we mean when we talk about SDOH, or the social determinants of health. And this is a pretty significant motivator in the healthcare field. The other issue that I really wanted to make sure that we understood here is value-based care, because that, combined with the social determinants of health, are really the key influencers on where all of this work is headed. Value-based care, think about it as quality over quantity. This is where healthcare entities of all kinds are incentivized to create better healthcare outcomes. So it's not purely as you see by this slide, a fee-for-service model, but it's more on a value-based. And before I continue, I wanted to do briefly a history of kind of how public and community transportation became part of the NEMT space. And it really stems back to, in the mid-1960s, the passage of both Medicare and Medicaid. In the early 1970s, there was a series of court decisions, class action suits were brought by Medicaid recipients. And basically, the upshot of these decisions was that if a Medicaid recipient couldn't get access to health care, then they weren't receiving their mandated health care. And it really began the process of states having to develop an NEMT response or model, every state a little different, to make sure that access was there. Not all states complied, most did, and they developed these Medicaid non-emergency medical transportation plans that were submitted to the federal government. Remember, Medicaid and Medicare, but we're really, in this case, we're talking about Medicaid. It's an entitlement program. And also recall that when we're talking about state plans, that means it's very difficult to, the federal government is just basically saying to the states, you have to provide this. You can develop your own models and methodologies for doing that. That went through the 1970s. And as we got into the 1980s, we started to see systems like HRDA and others were growing up all around the country. Rural transit providers who were serving, in broad strokes, a lot of lower income individuals, older adults, and were serving a lot of healthcare trips. And this was the beginning of kind of how public transportation and healthcare started to merge in a very small piece. And the Medicaid budget is immense at the federal level. And the NEMT kind of space is usually about 1% of the total Medicaid budget. So that's important for context too, when sometimes we wonder in the transportation space, why doesn't Medicaid pay more attention to this? It's 1%. It's a big number, it's in the billions, but it's still 1%. What ended up happening and leading us to where we are now is states were using what was called a fee-for-service model, as you see, kind of the old trend. And we're reimbursing transit systems, individuals, and others who were providing trips to get Medicaid recipients to healthcare. And that became very onerous for a lot of state Medicaid agencies. And as we moved into the current century, in and around 2000, there started to be a shift. It's an important shift. This shift was really this is where we saw the broker model emerge. And states and state Medicaid agencies wanted some predictability in what they were going to be spending every year on NEMT. And as well, they wanted to bring on an entity that they could shift the risk to, and I'll talk about that in a second, and also that they could charge with all of the compliance pieces that were connected to providing Medicaid NEMT. And what the private sector and these brokers promised was they started to develop a per member per month or a capitated rate model. And that would be where a broker would get paid a percentage for every Medicaid recipient in an area. Typically, and this number has fluctuated through the years, but it's usually between about 8 and 10% of Medicaid recipients in an area actually ever use Medicaid NEMT. But the fear among a state Medicaid agency was, remember, it's an entitlement program. What happens if 40% of the population shows up and wants trips? It's an entitlement program. We're going to have to pay for that. That was a frightening prospect to a lot of state Medicaid agencies. By working with the private sector and creating a capitated rate model, that risk was shifted to the private sector, to the broker. And the states had the two things they wanted. One, they had a number they could budget for, and that number wouldn't shift. And two, the risk of a lot of people showing up was given to someone else. And so in 2005, Congress here in DC passed something called the Deficit Reduction Act, and it kind of put into play this broker model that became all the rage among state Medicaid agencies. And we started to see sometimes statewide brokers, sometimes regional brokers within a state. Iowa, not too long after that, adopted a broker model as an example. This was a very common practice all around the country. So that model is around, and the next model that arrives is the managed care model, which is now kind of the preeminent model we see in terms of how transportation and NEMT are provided by state Medicaid agencies. And this model continues typically to have brokers, but it has the state dealing directly with the private sector insurance companies, managed care companies, that then will do the NEMT, oftentimes with a broker. One of the main changes that this model brings in is competition for Medicaid recipients and for customers on the private sector side. And we started to see a lot of innovation through this model being moved into the transportation space. And this is where you really start to see what's on the slide now, the value-based reimbursement model start to take root. And so that kind of leads us to where we are today, where we've got a social determinants of health kind of framework, a value-based proposition in the way healthcare is provided, and we've got managed care operations typically becoming preeminent in how many states look at what they do. Having been working in this in this arena for about 30 years, one of the first things that I've always noticed is, like, public transportation has its jargon, healthcare has its jargon, and ne'er do the two meet. And oftentimes words like access have a completely different meaning in the healthcare space than they do in the transit space. And it's one of the things that we often urge our members and people engaged in NEMT is we've got to learn the healthcare language, and not always expect them to understand all of the public transit jargon. And this was kind of a slide that I thought did a good job of kind of talking about the social needs, the social determinants of health, and then where that Venn diagram has the overlaps, where I think, we see a lot of benefit for both public transportation, but also, most importantly, for the recipients to get to healthcare and to get to routine healthcare. Danny was talking earlier there's always been certain indicators in the healthcare space that are areas where the healthcare arena is always seeking to improve. One of them is a no-show. And we know what a no-show is in public transit. Anybody providing on-demand mobility has run into those and knows they're costly. They're even more costly in the healthcare space. And oftentimes, a healthcare model, whether it's done through behavioral health or managed care or a hospital setting, a clinic setting, minor reductions in no-shows create major differences in financial outcomes for these entities. A 5-10% reduction in no-shows, which good public transit, good kind of networked transit can absolutely make happen, can be a massive savings. There's also other indicators, unnecessary use of emergency rooms, always one that healthcare is dealing with and knows the expense when somebody is only using an ER as kind of their primary care. Discharge. A lot of healthcare systems and networks, when they need to discharge a patient, they need to do it quickly. And the ability to do that effectively, oftentimes as well, has an important benefit in the healthcare space. So let's see, next slide. These are traditionally in the social determinants of health spectrum. You can see care management, pharmacy, behavioral health, which encompasses a lot of things, including things like substance use disorder, social services, food and nutrition, housing, an individual's financial standing, and what's nearby, from outpatient clinics to hospitals and these kinds of things. And the next slide shows that we really feel and have felt for a long time that transportation influences all of those other pieces. Your access to a pharmacy, to better food and healthy foods. We see food deserts in urban America just as well as rural America, where people can't get access to healthy foods. Case management, social services, all the pieces that influence and create that better outcome. We're going to go back to that value-based piece. Transportation has an impact on, and we've known that forever. If you work in the transportation space, you often hear at the local level, well, we could get better outcomes, and you could be talking about any type of outcome, if only people had better access, if we could get people here. Typically, transportation is not viewed as on par, so sometimes in communities, we'll see people build new healthcare facilities and build them away from any ability of a public transportation provider to serve it. And then they'll wonder why usage is down. We see that pretty regularly. Transportation is never thought of as the first thing. It's kind of always thought of as an ancillary service, but without it, the outcomes and the value-based outcomes we want to see are tougher to create. The ability here to define the value of transportation services is critical. And this kind of leads me to a piece that those of us, the folks that heard us certainly understand, and any other transportation advocates, there's long been running right alongside the NEMT space has been this notion of coordination. And it's taken on many forms and guises over the 30 years I've been in the business. It's made some transit advocates weary of, I never want to hear the word coordination again. Some have seen coordination move towards consolidation. We've talked about collaborations, all sorts of C's in these things, but coordination should mean multiple investors in networked transit and mobility, multiple investors that are creating a network that can create better outcomes, not just for their particular service, but for a multitude of services. Coordination, unfortunately, from time to time, we would hear in the 90s, what it really meant was doing more with less. And a lot of community transportation operators got extremely weary of that view of coordination, because at some point you can't do more with less. Funding has ceased being, it's always an issue, but it's not as dire an issue as it has been in the past. And so now, we've moved into the ability to effectively communicate with other entities and technology. The ability to weave together networks of different providers, both public and private, into a network that is ideally simpler for the customer or the patient, simpler for a healthcare entity to handle and get into what we all want to see. The ability to have someone be given a diagnosis of some kind that's going to necessitate returning trips to a healthcare venue to be able to say, I don't have access to a private automobile, or I don't feel comfortable driving to and from dialysis treatments, as an example. And the healthcare entity be able to tap into that network immediately. And at the same time, appointments are being scheduled, the transportation piece is being handled. That's kind of the model that a lot of us have been looking at and working on really for a generation now. I mentioned earlier that Medicaid was kind of the entree point, the entryway for many of these transit and mobility and healthcare partnerships. And that was simply because Medicaid had this access piece that, through those court cases I mentioned and through the class action suits, it was mandated. But in about 2015, 2016, the Medicaid transportation benefit was being challenged. We heard rumor, CTAA and many of our partners who work in this space heard the same rumors that the Trump administration at the time was interested in making Medicaid transportation optional at the state level. So stripping away what had been decided in those court cases and allowing states to opt out. Along with that, and in a very interesting kind of trend, we started to see both the private sector and Medicare. And when I say private sector, I'm talking about hospitals and clinics, hospital groups, all started to understand better the value of providing a trip. And again, we talked about reducing no-shows, reducing ER visits, help with discharge. All along that continuum, we were seeing this. And if you looked at in the early 2010 to 2014 period, Medicare, okay, and now Medicare, the only transportation it will pay for traditionally has been an ambulance. It will not pay for non-emergency medical transportation. Well, Medicare started to realize that there were many occasions in which they were forcing someone to use an ambulance when a much lower cost alternative, typically operated by an NEMT operation, or in lots of parts of rural America, a rural public transit operator, could do the trip vastly less expensively. And you won't be surprised that one of the first places that Medicare saw this was with dialysis. When a patient moves into that kind of chronic care, dialysis, end-stage renal disease, oftentimes they need to be coming into a dialysis clinic 3 times a week. And doing that in an ambulance became super expensive. So one of the first things Medicare started to do was look at, well, can we redefine kind of routinely scheduled trips that may not be of an emergency? They're scheduled, they're not emergency. Will we pay for those? And they started to move that way. And recently, a pilot that they had done in a handful of states showed great promise for savings on the Medicare space. At the same time, Medicare Advantage plans, which is a secondary health insurance plan that a lot of older adults will purchase to kind of work alongside traditional Medicare, give them some additional benefits. We started to see constantly Medicare Advantage plans offering a transportation benefit as part of their package of benefits. Could be taking someone, an older adult, we'll provide transportation to a gym. These kinds of things. Clearly, the private sector and these healthcare providers and these insurance companies were understanding that the cost of that trip was more than offset by the benefits. And again, back to that value-based proposition of providing services. So we started to see a lot of that. And we also started to see a lot of hospitals and hospital groups starting to contract directly with non-emergency medical transportation providers, directly with public transportation systems. Around this time as well, we saw the emergence of Uber and Lyft into the kind of transportation space. And they provided an important jolt into the system because on the one hand, they provided excellent technology. They introduced to many public transit systems how we needed to improve beyond a 48-hour advance notice and move into quicker response times for trips. Again, excellent technology. Unfortunately, some of the downfalls for them when it comes to NEMT training, some of those issues, the ability to serve people with disabilities, data sharing, not strong on those issues, but their arrival fundamentally in many parts of the country changed expectations of what an on-demand mobility service should look like, how quickly I should be able to access it. Should I be able to look at my phone and see where the vehicle is? All of those issues kind of come along. And we started to see in the last, I'd say 7 years or so, this trend towards, well, Medicaid isn't the only player anymore in the non-emergency medical transportation space. And this coincides really with the emergence of the social determinants of health model, what we've been talking about since I started here, and the value-based model. They both come around and they kind of bring all these pieces together. So one of the things that we wanted to talk about also was the inequalities in access to healthcare and where the NEMT system can really shine and eliminate some of those inequalities. The first one is an obvious one, but it's an important one we should never forget: accessibility. Prior to 1990 and the passage of the Americans with Disabilities Act, it was very hit or miss whether or not someone with a mobility device, someone with varying types of disabilities would be able to equitably access the healthcare system, even though Medicaid was saying you had to have these certain things. I remember going to meetings in this period of time, and you would hear entities say, well, why should we create accessibility in our retail space when no one with a wheelchair ever comes in? And well, the reason no one ever came in is because they couldn't. Accessibility has really changed, though. The ADA passed, public transit got up to speed quickly. Most of CTA's members back at this period of time already were moving, if they weren't already at full accessibility. But back then in the 1990s, accessibility was really viewed as like, does your vehicle have a lift or a ramp, the ability for someone safely to board the vehicle with a mobility device? Accessibility has taken on a lot of different issues now. There are many Americans with hidden disabilities. There are intellectual disabilities, visual and hearing disabilities, all of those now playing into what an accessible service looks like and why it's so critical in eliminating inequality and access to healthcare. So that's an important one, particularly when we take into account the growing percentage of Americans every census who report having a disability, and an aging population that is also increasingly likely to have some sort of disability. And further, accessibility, as it's been implemented in the transit and the mobility space, it improves access for everyone. I often would point to in the beginnings that ramp or that lift that somebody using a wheelchair might need was also very beneficial to a mother with a stroller, an older adult with a cart full of groceries. The calling out of stops on some public transit systems, as is necessitated by the ADA, helps people who are too busy looking at their phone and then, oh, this is my stop, just as much as it does someone with a visual disability. And we have found that a lot of what creates full accessibility for people with disabilities really improves the system for everyone. Another piece, obviously, is the cost. A lot of public transit systems really go out of their way in providing access to healthcare that is affordable to the individual. And, when an individual enters chronic care of any kind, I've mentioned dialysis, could be chemotherapy, could be physical therapy after a surgical procedure, something that's going to require multiple return trips. If there aren't ways to contain those costs to someone without access to a private vehicle, those costs are going to be just more than they can afford. We see that regularly. CTAA, we're committed to the importance of training of drivers. I mentioned earlier, we train 50,000 drivers a year in how to safely board a wheelchair or other types of mobility devices, how to safely work with people with varying types of disabilities, how to work with frail elders, how do you deal with bloodborne pathogens, what do you do if you're returning from dialysis and a patient starts to bleed? These are all very real issues that driver training is critical to. And I was talking with a reporter recently who was doing a story on on the need for training in the Uber and Lyft space. And it's clear, if you haven't been trained in how to do the specifics of what NEMT and access to healthcare creates as a driver, to say nothing of in the public transit space, the drug and alcohol testing regulations, the regulations that are all built around safe equipment, rolling stock vehicles, the drivers knowing how to safely do a pre-trip inspection of a vehicle. All of these things may seem mundane, but when you're providing someone a trip, HRDA and other systems like it around the country, they know the first priority is always safety. And safety happens with good training. Regular training that updates regularly to deal with, newer technologies, to deal with, the types of devices that people will use as mobility devices are changing all the time. Driver training, quality of equipment. I talked about the emerging on-demand model, and indeed, Uber and Lyft created kind of the technology-driven on-demand model. But we always like to say CTA's rural and specialized operating members that have been serving their communities with what initially were called dial-a-ride services back in the 80s, they're the originators of on-demand mobility. We've been doing it before there was an internet and phones and all those things. And the place we're at now is this merging of the technology basis that Uber and Lyft introduced and popularized with the customer-based emphasis that a lot of traditional CTAA operating members had. And that's the emerging on-demand model. There are new technologies all the time. Some people like to call them disruptors, but what they're really doing is taking advantage of services and infrastructure and trying to put multiple types of operators together in a single methodology for a passenger, so that they can seamlessly transfer if need be, and they can decide, how to do it. And, the other really big piece when it comes to inequality in access to healthcare is one that often gets overlooked. Is service available? Are there alternatives to the private automobile? In most of rural America, you can find those, but there are some that, particularly large regional rural operations, they may only be able to serve a community once a week. We see that. So coverage, and we've also seen in many parts of rural America, the healthcare system leaving. And when I started at CTAA in the late 1980s, most rural communities had their own healthcare facility. I'd say today, what you're more likely to see is a regional, multi-county healthcare facility that's drawing in from a larger catchment area. Service area coverage is critical when it comes to equality in access to healthcare. And so all this leads to, I think, the point of why HRDA would be holding a conference like this, and that is partnerships between healthcare, between other types of modes of operation, partnerships with technology providers, a partner with kind of data analytics. The world of non-emergency medical transportation is changed. And we've just gone through a pandemic for 2 years. We're not out of it yet. And in this pandemic, we've seen partnerships with public health And at CTAA at the federal level, we were really gratified that, one, we saw the federal government understand that operations like HRDA at the outset of the pandemic needed to have and be allowed the flexibility to transport food and groceries and prescriptions to people that they used to take to those facilities, which were now either closed, or at that point, people didn't want to, people were isolating themselves. We saw that change. Immediately upon the vaccine starting to come out, CDC comes to CTA. How can you help us provide better access to rural residents, to older adults and older communities, to people with disabilities, to the vaccine sites? All of these things are creating partnerships. And we've been urging that for a while now at CTA, that our members should, if you're operating, whether it's a large rural operation like HRDA, smaller rural operations, smaller city transits, you maybe are a private sector NEMT operator, all of those need to be actively partnering with varying agencies and operations in their community. Again, let's go back to the value-based model to create better outcomes. And it's good for public transit, which for the longest time has only really been able to talk about our benefit in the community is how many people we transported last week, last month, last year. But when you can add those numbers to, and this many of them went to healthcare, and that reduced no-shows at local healthcare facilities by 25%, which equated to X. That created access so that we've reduced unnecessary use of emergency rooms over here. I mentioned here mental health and substance abuse, coinciding and really preceding the COVID-19 pandemic. The just terrible problem the country went through with addiction, substance use disorders, overdose deaths, and we're not out of that. The most recent figures I saw, 90,000 Americans died of overdoses in the last 12-month period that was evaluated. It's not being talked about as much because we're dealing with a pandemic that unfortunately is creating even worse outcomes. But it's not like that's just been solved. And when it comes to substance use disorder treatment and recovery, many of us see the same types of chronic transportation needs that we see with dialysis. It's regular and return trips to facilities. It could be people needing to go to a methadone clinic and or other of similar type of clinics. These are regular trips that are being created that, as we talked about, aren't affordable to someone to do all the time. Many people who are experiencing substance use disorder don't have vehicles, don't have driver's licenses, are in a place where we don't want them driving, but we need them to have access to the treatment and recovery facilities that are being created around the country. Those of us who are in the transit business, we see that's a mobility need, that's a transit connection. So partnerships for these systems are going to be critical. HRDA's really an innovator in this space. They are They're an innovator in the application of technology. They're an innovator in successfully finding partnerships and finding a role for their brand of public transportation that absolutely is dealing with the social determinants of health, because it's providing access to housing, food, healthcare, counseling, all of those things that go into, jobs. If someone's working, chances are they're a lot healthier. These are what the data tells us. HERD is doing all those things and deploying technologies. The point here is there's always more, and they're always different and emerging healthcare crises. The last 2 years being one like we've never seen before, and I hope we never see again. These are all the kinds of places that we're going to be working. So CTAA, our annual conference is literally in 2 weeks in Louisville, Kentucky. We have an entire track of non-emergency medical transportation training that will take place there. There's going to be lots of discussions of applying technology that might be outside of the NEMT track, but can also be used by varying agencies to do that. Partnership building, advocacy, outcome-based transit, all of these issues are going to be brought in and will be discussed at length at our conference. So, I'm going to hopefully have some questions here because that was a lot to cover in a relatively brief amount of time. That's my email address. Please, if you have questions that you don't want to fire away at, feel free to send me an email directly. If you're seeing things in your community, or if you're in the healthcare space and you're seeing needs for better transportation, I'd love to hear about those, because that dialogue and kind of helping to engender and engage both transit and healthcare has been something that kind of we've seen at CTA as as one of the real important roles that we play. So I guess Taylor's with me. She's been putting some links in the chat box. I encourage you to look at those links. There's all sorts of good stuff in those pieces, and I'm looking at the chat now to see if there's any questions. I see Moises mentions something about some of these quote unquote Frankenstein opioids, or things with fentanyl and other pieces that are, terrifying in terms of the negative outcomes they create, and the overdose issues that they create are very serious and unfortunately very, very real. And we must mention that rural America in many places was the epicenter for a lot of those issues. We don't always, we tend to lag behind in rural America, a lot of things. Unfortunately, rural America does not lag behind in substance abuse disorder issues. And it's a critical one for rural systems to engage around. But I totally agree with you on that, Moises. It's a scary proposition, what's happening out there.
Please feel free to put any questions you have for Scott in the chat. He has a wealth of information, so now's a good time to ask anything that you would like to ask about rural transit and healthcare. Scott, this was a great presentation.
Oh, well, thanks, Julia. I think the thing we want to see, and I think where the future's headed here, is that space where at that moment of engagement with an at-risk patient who is what we like to call transportation disadvantaged for whatever reason, the handling of the transportation challenge along with the scheduling of appointments. That's that moment where we've got a patient there. The technology is there now to make those kinds of things happen. And I just really hope that we see more of that at that point, because I think that that's where, in terms of, again, going back to the outcome base, I think that's where we can partner best with healthcare to do the real goal here: a healthier individual, a healthier community, avoiding unnecessary emergency room usage, all of those things.
I agree. And if people are interested in learning what HERD is doing on that front, we will be having a session when it's what's up with HERDA later today, that we will be talking about our healthcare connector project. That is a $5 million grant that we received. And that's some of the stuff that we'll be talking about there too, that we're really looking into. So,
well, here's a question from Kayla, and it's a good one. The integration of public transit and paratransit joined together. Paratransit, for those who haven't heard that phrase before, has tended to be fully accessible services designed for people with disabilities, oftentimes meaning it's part of the public transit suite of services that have to be provided with the Americans with Disabilities Act to meet the ADA. This is a tough one, Kayla, because I had conversations with some of our members in Florida yesterday about exactly them seeing, particularly in the urban parts of Florida, but you would see it in Iowa, certainly in Des Moines, Cedar Rapids, places where you have fixed route bus service. And that fixed route service by law has to have a complementary ADA paratransit service that runs alongside it. And you end up, and that is the most expensive type of service for for a fixed route bus operator to provide. And there is oftentimes a kind of balance. Kayla asks, can they coexist? They absolutely can and should. But that has to be kind of a constant communication and engagement between those communities. If you look at like ADA, it requires a 48-hour advance notice. I've never thought that one's quality of life is all that high if anytime you want to go somewhere, you've got to schedule your life 48 hours in advance. I think most of us here in this room, if you really thought about that, that would reduce your quality of life. So the way that these things coexist is where we can make sure that fixed route services, where a bus is going through every half an hour, are fully accessible, drivers are trained, and it allows people with disabilities to lead more fuller lives that don't have to be led 48 hours in advance. Also, with the balance being that paratransit piece, that on-demand model sometimes is the best and only way to do things, and that is done and is offered as effectively as possible. And that's the balance. We should always be careful about trying to think of people with disabilities or even older adults as monolithic entities where they're all the same. They are all different. Everyone with a disability is different. And the difference between a 68-year-old senior citizen and a 98-year-old older adult are completely different. And they require different types of mobility to keep their quality of life up. And that's where these kinds of communications, that's where the coordination that and the technology adaptation that we're seeing, that's where all this stuff comes together. It can work, Kayla, but oftentimes there's problems with that.
And Scott, just to piggyback on that, because HERDA contracts with Cyride to do their paratransit, we have that funding issue so it's not always as simple as it seems when you're a rural system that only can operate in rural areas, but you're partnering with paratransit services, and that city also falls into your rural region. And FTA just hasn't caught up to fixing that issue quite yet.
It's a hard one. You know, I know Danielle's going to be talking about the CCAM. That's the Coordinating Council on Access and Mobility. But what really that is an FTA, Federal Transit Administration led effort to bring education, health and human services, housing, all of them that are benefiting from good transit. They're getting better outcomes in their programs because of public transportation, and having them at the very least come to the table and help plan and build services, and ideally funding some of the services or investing in some of the services. Abigail asked about partnerships. My colleague, Amy Conrick at CTAA, could do a whole session like this on the different types of partnerships that we see between healthcare and public transit. I would characterize them, Abigail, right now to say they're increasing, and both sides are coming to the table with, I think, a better understanding of what the other side wants, and just as importantly, with the patient, in this case, in mind. But you know, CTA, we've done a lot of projects around the country, and if you email me, I can get you some examples of these that go everywhere from the basic scheduling piece that we talked about to more detailed partnerships where, you know, we had a project in West Virginia that funded getting people to substance use disorder treatment and recovery. That grew into one that's continuing. So there's all manner of different ways to do this. There's no one size fits all. The one thing, though, that's common in any of the success stories is engagement, real engagement and collaboration, and not just people arriving at a table with a list of demands.
Scott, Amy's on here if you wanted to have her chime in real quick.
Well, she's being a little shy right now, so I'm not gonna call her out. But if you send me, thanks, Brooke, for putting my email address. Abigail, if you send me that, I'll link you up, and we can talk about different engagements. CTA is the chair of our board, runs a rural operation in South Dakota. She works directly with the healthcare system in the whole western part of South Dakota, does a lot of discharge work for them. It's kind of a private public partnership that they've worked on. That's one example. There's tons of systems at the small city and rural that are working directly with hospitals, and we've got a lot of CTA members that work with like VA facilities for veterans health care, and we've got tribal members that are working with tribal healthcare facilities. So we've got a lot to offer there.
Any other questions for Scott real quick?
I appreciate everybody's time today. It's always an honor to talk with a group of people about an important issue like this. And I wish Julia, you and your team the best for today. You're pulling together a lot of really great people. So, you know, there's going to be some really cool outcomes from what you're working on here.
Yeah, well, I really appreciate that you and Taylor took the time to attend today and share some really good information with people that I hope found very useful. We did. So we always appreciate that. And this is being recorded, Scott, so I can share that later if CTA wants to.
Yeah, we'd love to do that.
Publish it on your platform so that other people that couldn't make it can hear what was said too.
Definitely.
Okay.
And all the links that Taylor had been putting in the chat will also be sent out to everybody after this as well. So if you didn't catch that in the chat, we'll be sure to get it to you afterwards.
Great. Thanks, everyone.
Okay.
Have a good rest of your day.
Thank
Thanks, Denise.
you.